This is the Northern Ireland Assembly Committee Room.
I declare the meeting open to the public online. Can I welcome members who are participating today by telephone conferencing to maintain social distancing within the Health Committee? And those members today are Pat Sheehan, Colin McGrath, Orlia Flynn and Paula Bradshaw. And I'd like to remind members about protocols regarding the use of electronic devices. We have one apology for today's meeting from member Alex Easton. And there are no items in Chairperson's business today. I'm moving now on to the draft minutes. Item 3, I refer members to the draft minutes of the meeting held on the 20th of May, which are at tab 3.1 of the meeting pack. Are members content with the minutes? Content? Content on the phone? Content. Thank you.
Yeah.
Okay, members, we're now moving to our first substantive briefing of the day, and can I refer members to your briefing note in table papers at tab 5? Can I advise members that the Commissioner for Older People is here today to brief the committee on the impact of COVID-19 on older people. I would like to now welcome Mr. Eddie Lynch, Commissioner for Older People. Eddie, are you there?
Yes, Chair, yeah.
Miss Evelyn Hoy, Chief Executive of the Commission for Older People. Are you there, Evelyn? And I'll check if Miss Emer Boyle, are you still with us there, Emer, Head of Legal and Policy Research?
Yes, I am, Chair.
Thank you. And I'll just check back with Evelyn. Are you there, Evelyn Hoy, Chief Executive? Yes. Thank you. If I could ask all members on the phones who are not speaking to keep your phone on mute, please. That helps with the reduction in feedback. And also for the Commission members and indeed for members on the phone, just to identify who you are so that everyone else on the phone and in the room can tell who's speaking at any given time. But I'd like then to go back to yourself, Commissioner, and ask you to go ahead and brief the committee this morning. Thank you.
Okay, thank you, Chair. I'd like to start by thanking the committee for the invitation to provide evidence to the committee in these most worrying of times for older people. I'd also like to thank the committee for the important work and role that they have played during this pandemic in scrutinising the various authorities on a range of issues in the past number of months. I'm joined on my call today by my senior management team, as you know. That's Evelyn Hoy, the Chief Executive, and Emer Boyle, the Head of Legal and Policy Advice. Representing older people across Northern Ireland from ages 60 to 100 plus in the context of this pandemic in recent months has not been straightforward. There are clearly a number of different groups across this wide age spectrum that have different levels of risk to coronavirus. During the pandemic, much of what would be deemed to be the normal work of the company office has continued, supporting older people and their families, with our small team working mostly from their own homes and attending meetings using phone or video conferencing technology. In my short address this morning, I will give my view on what has happened during this pandemic to date and my experience of trying to safeguard and promote the rights and interests of older people during this time. I also want to share some of my current concerns and those concerns going forward in the short to medium term. Up until this point, there have been a series of key issues that myself and my team have been dealing with during this pandemic. These include, but are not limited to, COVID-19 planning and preparation, PPE, reporting issues, and testing issues. If I cover each one very briefly, myself and my team were involved at early stages in giving advice to authorities on the need for care homes to receive appropriate support as we saw the pandemic come towards our shores. And in those conversations, we outlined the needs of the sector in terms of staffing and extra support that they may need to cope with the oncoming pandemic. PPE has been a huge issue. In the early stages of this pandemic, we were working very hard with the authorities and providers to secure appropriate and adequate PPE for care homes and domiciliary care workers, particularly in the early weeks of this pandemic. Reporting has been a big issue. For many weeks, I was arguing for better reporting on the victims of this coronavirus. In the early stages, I had been concerned that deaths in care homes were not being reported. So there has been progress made in the information that has been put into the public domain, which I think gives a much more accurate picture of the situation. But we still want to see further information being published. We've seen more information on infection rates and numbers of deaths by location, which is helpful. But I'd also like to see more data on survival rates as well over the coming weeks ahead. And the issue of testing, for some time I was concerned that we hadn't rolled out the level of testing to protect or help to protect our residents in care homes. I've called for many weeks about the need for a rolling programme of universal testing, and I'm pleased now that the Minister has announced that, albeit many weeks into the pandemic. It's unfortunate that I have to regret to inform the committee that really, while progress has been made on each of the issues I've mentioned, it did take longer than I would have liked, and it was an uphill battle for getting the support for the care home sector on a range of these issues. In terms of the current issues, there are two specific issues that I am focusing on at present. The ongoing rollout of the testing programme that was announced by the Minister, and the other issue is the potential impact on older people as we as a society emerge from lockdown and ease the measures. In terms of testing, I welcome the recent announcement by the Minister that universal testing will now be rolled out across all care homes across Northern Ireland so that all residents and staff can now be tested. While this is not a guarantee to stop COVID entering care homes, it should help to try to identify positive cases at an earlier stage and allow authorities to manage outbreaks more effectively. I still have a couple of concerns with regard to the testing. One is the length of time to test all the care homes. At this stage, the Minister's commitment is for everyone to be tested by the end of June, and that's something that's still quite some time away. And the other issue is the regularity of testing. The Minister has mentioned about every 14 days for staff or residents to be tested, but I would like to see that increase and have it on a more regular basis to increase the effectiveness of the testing regime. In terms of emerging from lockdown, I think it's important to highlight to the committee that the majority of people aged over 70 have now been shielding for 11 to 12 weeks. This measure was, I believe, completely necessary, as the grim statistics on the effect of coronavirus clearly shows. However, we can't underestimate just how big an ask this was for our older population, and for many people it has clearly taken its toll at this time. The lack of contact that older people have had with family, friends and wider society it's affecting all of us, but the impact on older people can be particularly profound, given that many already experience loneliness in their lives. Most older people during this pandemic have had to rely heavily on family members, friends and neighbours to do their shopping and try to keep in contact using whatever phone or online media possible. But unfortunately, we know that many older people do not have access to this technology, and that has left them increasingly vulnerable to loneliness and isolation. Older people are not a single homogenous group, and we have heard from many older people who are concerned about being advised to lock down for indefinite periods of time. I'm also hearing from families of older people in care homes who are concerned about the impact that their lack of contact will have on their loved ones in the medium to longer term. For older people who are advised to continue to shield, we need to look at how we will support their needs going forward, including both their physical and mental health needs. It would be wrong to base future advice on longer-term shielding on age alone. Advice and guidance must consider a range of factors that put people at risk. I'm also very concerned currently that easing lockdown will heighten the risk to care homes, as it is likely that these measures will lead to an increase in community transmission of the virus. This would mean that nurses and social care workers may have a higher risk of being infected and to bring COVID-19 into home settings. This is why the testing, tracing and isolating system is up and running before we make any further major easing of lockdown measures. This committee is a brief overview of the key areas I've been working on during the past few months, and I'm very happy to discuss these further with you this morning and take any questions that committee members may have. Thank you.
from myself. First of all, I noticed within your presentation there that the issue of discharge policy into care homes hasn't been dealt with. Have you any concerns around how the discharge of cases out of hospitals was managed, and any potential that had to worsen the situation in care homes?
Thanks, Chair. I think this has been a concern right from the start of the pandemic. We knew that in the early stages, and when the health system was preparing for the pandemic arriving, it was clear that one of the aims was to free up as much space in hospital settings to increase capacity if hospitals were flooded with COVID cases. And part of that was the discharge of older people back into care home settings, and this was at a time when there wasn't testing happening. Now, there's no evidence that I know of that those people, would have had COVID at that stage, but during the pandemic, since it arrived, we have heard, evidence of certainly older people being transferred out of hospital settings without being tested and relocated back into care home settings. There is no specific evidence to show that they may have had COVID and contributed to the spread, but we do know that actually happened in many care homes, and we have a number of cases of families who brought concerns to my office in relation to people being brought into homes without testing, and concerns from families that may have contributed to outbreaks or the spread of COVID. So there's not any concrete evidence of that, but in terms of people with COVID being brought into care homes, but certainly that it was the case that older people were transferred out of hospital settings without being tested.
With the department in relation to that, or do you plan to engage around that issue at all, Commissioner?
Yes, this issue has been on the agenda now for some period of time. The department did move on this matter some weeks ago, where they confirmed that people would be tested at least 48 hours before they were moved out of hospital settings into care homes. So, I think that it's absolutely vital. We know from the evidence of elsewhere, but we also know from our own situation here, the best way to protect people in care home settings is to prevent the virus getting in the first place. So it is totally logical and absolutely necessary that anyone who may be exposed to COVID, as they would naturally be in a hospital setting, are tested and assurance is given that they are COVID-free before being transferred into a care home.
Thank you. And the second question from me then is, you've referenced the testing, and again, that's something that I think we were also very keen and welcomed the fact that there was additional testing being done and that all care homes are going to be tested on a rolling basis. And you've mentioned the 2-week period and your concerns that the 2-week period may not be sufficient. What would your preference be for a testing regime?
Yes, well, Chair, I have had a number of conversations with different organisations about this. I am not the expert on this, but I have spoken to other authorities. There doesn't seem to be a very exact recommendation, but I have spoken to other organisations in Scotland, for example, where there has been some evidence from specialists that have suggested that testing really should happen every 3 days of staff and residents. Obviously, it's not an exact science. We all know that this virus, you can be negative one day and positive the next. And, in that sense, you could be testing people every day. But I think we have to be realistic in what's achievable here. But certainly, for me, I think 14 days seems a very long time between tests. And I would certainly be wanting to see, us moving towards a system that may be looking at twice a week that people get tested.
Thank you. And then the issue around the guidance and the shielding letters and the guidance in that, and we did discuss that with the Minister yesterday, and I think we welcome the fact that there's going to be more nuanced guidance provided in terms of people's individual conditions and circumstances. And we also raised the issue of carers for people who are shielding, who themselves may not be shielding and therefore don't have the protection that comes with that status, difficult as it is. But that those people have a responsibility to the person they're caring for, who may be shielding and may have additional pressures on them, especially where they are essential workers. But I'm just wondering, in relation to the whole range of issues around that shielding letters, are you involved in that discussion, or do you have any views in terms of how that should be done?
We're not directly involved in the conversation in terms of the guidance, but one of the things I have spoken to the Department for Communities on is I've said to them that there needs to be work done between the Communities Department and the Health Department on this matter, particularly for people who will have to shield longer term. I'm very concerned about, there's a lot of older people who have contacted my office who have said, look, this has been a struggle. I've been happy to shield over the last few months because I know the danger of this, but there's a big difference in doing it for 12 weeks and 12 months. And I think there are many people who are really struggling with that. And I think as a society, there's a real challenge here. I think the other thing we need to consider is that up until now, there has been a great response from the community in terms of providing that level of support that's needed for people shielding. So that we've seen great volunteering being done by sports clubs, church groups, community organisations. But I think as the lockdown eases and more people go back to work, obviously the numbers of people who can provide that support will reduce as well. And not only just that, but also within families as well, because we do know that families have actually, many older people who were concerned have their families decided to stop their domiciliary care packages just simply because they were able to care for their loved ones themselves because they weren't working. And it is a concern of mine that we have heard some stories that families are being told that, when things get back to the new normal and people are back to work, that people will have to reapply for those packages. And that's deeply concerning because those families only stepped in and took that mantle up because they were able to. But, there's no evidence there that older people suddenly don't need that support. So I think that's an area of concern as well, Chair, when we ease out of the lockdown.
Okay, thank you, Commissioner. I'm going to now go to members. I'm going to go first of all to Deputy Chair Pam Cameron, and then I'm going to go to members on the phone in the order in which they came in, and then I'll come back to, we then have Jerry and Alan in the room. So I'll go across to Pam.
Thank you, Chair, and thank you, Eddie, and your team. And just to say, wish you all the best, Eddie, with your second term in office, and just to thank you and your team for all that you're doing to champion the needs of older people at this critical time. You'd mentioned there, Eddie, testing and your desire to see that happen very frequently, and I completely understand that and understand the need for that. I'm just wondering, what way has your office been dealing with complaints coming through, and are you getting complaints from residents or family of residents who are concerned about the actual testing process, because we know it's quite intrusive and unpleasant, and is there a reluctance, or is it a struggle to have those tests done, and do you see that being a problem going forward, even if testing is made more available more frequently?
Okay, thank you, Pam. Thanks for your comments. I think the issue of testing, we haven't really received many complaints or as such from families in relation, against or opposing testing. I would say that you raise a very good point, though, in relation to the actual process itself. It can be quite intrusive. It can be quite unpleasant, and we have heard some, evidence coming back that the testing in care homes is taking longer to do than was originally thought, and that's just simply because obviously you're dealing with older people with different conditions, people with dementia who don't know what's happening, and obviously may resist that. So I think it is a delicate issue. I think it's something that will be there's practical problems with, but I would say the overwhelming number of families who have contacted me and the team in the past, over the past number of months, have been concerned more about the lack of testing and have been in favour with testing being ramped up. So, and since the Minister announced, moving to a rolling programme of testing, that has been broadly welcomed. So, I might just ask my colleague Emer Boyle, maybe, who's dealing with some of the cases coming through, maybe if she's anything further to add to that.
Thank you, Commissioner. I would confirm that whilst we have had many contacts from families of relatives in care homes, we haven't had any raised concerns about the intrusiveness of the testing process. It has been, as the Commissioner outlined. Any concerns around the intrusiveness have come more from the officials and people explaining the difficulties with administering the process.
Emer, just on a technical point there, it's Colm here. There's quite a lot of distortion on your voice there. I wonder if you're using headphones. If not, maybe you could try headphones if you have access to them, or maybe there's something else on in the room. But there's a bit of distortion in your voice. It was loud enough, but quite distorted. So maybe just the next time you're speaking, if you can try something slightly different. And I'm going back to Pam then.
Thank you, and thank you for your answers there. I suppose in terms of complaints that you've received, Eddie, have the numbers increased, and if so, by how much? And are you concerned that complaints might not be able to get through because of the lack of communication, because of the lack of technology within the care settings, and maybe even due to the lack of the stress of the pressures of work in the care setting? So I suppose could you give us an update on what complaints or reports you have received, and whether that's changed in recent times, and would it be what you would normally be receiving in terms of complaints?
In terms of the complaints received, I mean, it has been, broadly speaking, I would say that it's obviously the vast majority of complaints have been around the issue of the pandemic, where previously, we would have had maybe a wider range of issues that have come up. So I would say that the vast majority of our complaints that we've had in contact with families have been around care homes, although we do have some issues around domiciliary care as well. But I suppose the other side of it is we have had quite a few calls from people who are also saying, I'm in my 70s, I'm in fairly good health, I don't want to be locked down longer term. I feel that I can, manage the risk to me. I want to have choice to going forward longer term. And I suppose we also have heard from the older age group, there are people who may be well into their 80s who are saying, I understand the risks involved here, but, that I don't want to face possibly the last year or two of my life being locked down and not seeing families. And so I think this is what we're grappling with in terms of, older people. They're not one group. They're very much different people, like any other age group, with their own opinions and different views. But I do think what is really important to stress is that all the evidence continues to show that the people most at risk from this coronavirus are in the older age category. The statistics are stark. 80% of deaths in Northern Ireland are in the 75 plus age group. And, the conversations I've had with a lot of the medical experts, the virologists, epidemiologists, have been, very much that age is a key factor here, that people are more at risk. So whilst we all want to ease out of lockdown and get back to some sort of normality, I think it's very important that the messaging remains very strong, that the virus is still here, it's still as deadly as it's ever been, and there are particularly groups in our society who are susceptible from it. So yes, we have to follow the instructions, but it's a complicated picture for older people. Clearly there are those with underlying health conditions who are very much at risk if they get it. But there are many older people out there who do want to be given flexibility to get back to some aspects of their life.
Chair, can I just come back in? And thank you, Eddie, for that. And I'm glad that you recognise the complexity of the situation and respect the needs and wants of those individuals, who, which are all very different. Would you be supportive, Eddie, of introduction of new measures to allow, safe measures obviously, to allow some form of visitation into care homes where that has been requested?
This is something that is being talked about now. There are, I'm aware now of care home providers reporting that they are seeing the impact of lack of social contact between residents and their families, and they're seeing the deterioration of some people as a result of that. And I think that's a really serious issue that we need to consider. But it's a fine balancing act, the how we can do this in a safe manner. I've had many calls on a weekly basis with colleagues across the UK, with different organisations, including the Welsh Commissioner on this, and we are looking at this issue in a lot of detail. We are very aware of about how families don't want to go long term in terms of not having the contact with people, and given we know that people's average stay in a care home is not usually that long, maybe it's around 18 months. If we're starting to say that this could be a longer term thing over another year or so, then obviously that has huge implications for families seeing their loved ones. So I think it's something we do need to be looking at. It is something that I'm looking at very closely. If there is a way of safely doing it, then I think we should definitely explore that. We've heard some examples elsewhere where some care homes have organised like drive-through visits, where there's still a limit to the contact they can have, but it actually gives at least more of an opportunity for families to see their loved ones in care homes. So, but I think there's difficulties as well, and I think the other thing we have to recognise is families themselves have different views on this, and it is getting that balance of the ring of steel around care homes, but also recognising the social and emotional needs of the residents and their families.
Thank you, Commissioner. I'm going now to the phones. I'm going first to Pat Sheehan. Pat, are you there on the phone?
Yes, I am, Chair. Thank you. And welcome, Eddie and Evelyn and Emer. Thanks for your presentation. Eddie, I wanted to talk to you on a more general basis about care homes. And, we can't divorce this COVID-19 pandemic from the problems that already existed in care homes. And I know how familiar you are with Dunmurry Manor and the scandal that took place in there, and other homes, particularly those homes run by Runwood. And of course, Clifton House was more recently in the media, and we had the Spotlight programme the other night. And we heard in it that 26% of care homes in the north, according to RQIA inspections, were having infection control issues already. And I suppose this whole issue of the virus has brought into sharp relief the deficits in some, and not all care homes, but in some of them, and some of them that have been particularly badly managed. So I'm wondering, that's a bit long-winded to get to the question, what would you like to see coming out of all of this in terms of the management and regulation in care homes? Thanks.
Thanks, Pat. Well, I think the simple answer to that is that you're quite right with what happened in Dunmurry Manor, and unfortunately some of the stories that are coming out of Clifton Nursing Home in the past couple of weeks, have been depressingly familiar for myself and my team, because they do mirror a lot of the issues we uncovered in Dunmurry Manor. And I suppose the simple answer to your question is, what I would like to see happen is the implementation of the recommendations from my Home Truths report, which is almost 2 years out now at this stage, because I think some of the issues that are emerging in Clifton house were very similar to the problems in Dunmurry Manor. And I think one of the most disturbing aspects of my investigation was, for me, the number of chances that care homes had to fix what were quite serious failures of care, and the length of time it took care homes to do that. And I think what we have heard in Clifton in recent days has been a home that has struggled with infection control measures over a significant period of time. So for me, it's very much the issues that are being highlighted, and any other issues that have been highlighted really since the Home Truths report on Dunmurry Manor came out. They aren't new issues. There are issues of problems within the system that need to be changed. And for me, it remains totally unacceptable that the length of time that we have to wait to see improvements is as long as it is. And it's completely unacceptable for the residents. This is the home of their home that they're living in, and where we see failures of care, that is impacting on every single resident on a daily basis. And it's just not good enough to have months and months go by before the management in homes fix that problem. So, if there's, if some good is to come out of what's happened in recent months, I think it's highlighting once again the need for change, the need for changes to how we regulate and inspect our homes, how we take a tougher stance and insist that homes make the improvements much more quickly to protect those who live within them.
Thanks for that, Eddie. And just a final short question. I know many experts are saying that from here on in, we're going to see new viruses appearing more regularly. So it stands to reason that we should be prepared for that eventuality. And I'm sort of been banging the drum about South Korea and the record they have there, that not one person has died in a care home setting in South Korea, and which goes to prove that if you have been prepared and in a state of readiness for whatever comes at you, you can deal with it. And I just wonder, do you think there was too much focus on the acute care setting here at the outset, and that care homes were basically left by the wayside and left to look after themselves effectively? Thanks.
Yeah, I think you're quite right in terms of the future threat. I mean, we're still very much in phase one of this. There could be other waves come down the line, and I think whilst this was new for many authorities dealing with a pandemic like this, and we hadn't as a society dealt with this before, the lessons that clearly have to be learnt have to be put into place. So if there's a second wave or third wave, that we're much better at protecting what we know are some of the most vulnerable locations and residents of this virus. But you're quite right. I mean, in terms of other types of viruses, the homes have to deal with things like infection control regularly anyway, even before now, outbreaks of flu, norovirus, MRSA. And we have to be learning from the mistakes that there have been in terms of getting things in place more quickly. I think at the start there was no doubt that the focus was on the acute settings in our health system. There was deep concerns about it being overrun and flooded and not being able to cope. But I think in the midst of that, there was organisations like my own and other organisations who were advising government about the vulnerability of the care home settings and that more action needed to be taken at an earlier stage. So it has been frustrating for me personally to see how so many of the homes were slow to get the PPE that they needed. The testing regime, I believe, should have and could have been rolled out at an earlier stage. We saw from other countries, we did have the advantage of seeing what the terrible things that were happening across Europe as the virus came our way in Italy and Spain and others. And we knew that people in care homes were very much at risk if the virus got in there, just by the nature. So, I mean, there was clearly a slowness in moving to protect that has led to an increase in infection. We are where we are now, and we have to make sure that we do everything within our power at this stage to provide that ring of steel, to provide that level of support in the testing and tracing. I still think there's more that can be done. I think there could be more rollout of testing. There's nothing inevitable about this. As you say, other countries had learned from the past and had taken different approaches. So there's not an inevitability about victims in care homes by coronavirus, but we have to learn the lessons of what's happened in previous weeks and months and apply that now.
Okay, thanks very much for that. Thank you.
Thank you,
Thanks, Chair.
Commissioner. Yep, thanks, Pat. And moving then to Colin on the phone. Colin McGrath, are you there on the phone?
Yes, indeed. Thank you very much, Chair, and thank you to the panel for the presentation. I suppose the comments and questions that I would like to ask kind of follow on somewhat from what Pat has said there, because in the pandemic and where we are, I suppose there are two things. Number one, we can reflect back and see what has happened and say, what can we change for going forward in the future? But I suppose I just want to probe a little bit. You had mentioned there already about seeing what was happening in Italy and Spain. And, I mean, it was very obvious that there was a major issue within care homes in both of those settings, that there was weeks and weeks of a heads up, as it were, to ourselves that was coming down the line. So can I ask just, if you see that as the Commissioner, what action did you take to go in and say to ministers and departments that there is an issue here and it's coming down the line? As the Older Personers Commissioner, I give real weight to seeing what's happening in other places, and you need to do something, because we would kind of, I think, generally accept that the eye was taken off the older people's homes and the focus was on acute care, and there was at least a 6-week or 7-week lag between the effort that was being put into the acute sector versus the care home sector. And when you add that with what same was in Italy and Spain, there's probably about 8 to 10 weeks of a heads up that we had. So can you detail to us just the representations that you were making, and were you finding it was a closed door, that nobody was listening to you, that you were banging your head against the brick wall trying to raise the issues of what was happening in the care home sector?
Thanks, Colin. I mean, in the early stages, it was clear to us. We were very much on a daily basis in contact with the providers on the ground, and we were seeking reports about what was happening, and many providers were coming directly to my office raising their concerns. So that was our intelligence, I suppose, and what we were doing in those early stages, myself and other members of my team were in daily contact with officials in the department raising the concerns on the ground. The big one at the start, really, in the first number of weeks, was on PPE, and we were back and forward many, many times, stressing the need for PPE to be released into care home settings. There was many providers did report to me that whilst they were requesting PPE, that was not forthcoming, or it was slow to get out to them. And we have heard many of those providers believe that as a result of that, that the focus was very much on maintaining some supplies for the acute settings. But I mean, I've been getting assurances in the early stages. I spoke to very senior officials within the Department of Health on this, where they were given assurances that the trusts were to provide the homes with that equipment where requests were being made. I think what we had was in the early stages, some homes were being told it was your responsibility to seek the PPE and get the equipment in themselves. But it became very clear that was unrealistic to request that from the homes as well, because as the virus spread globally, it was clear there was a global shortage in PPE, and what providers were saying to me was, we don't have a chance of getting these orders now because we're competing with countries who are making orders and requests. So they were struggling very much in the early days. They expressed real concern, as I did, to officials around why that was taking so long to get out. And, that has been well documented. Many providers have publicly said that they felt left behind, that they felt they didn't get the guidance and equipment that they needed, and they felt they were playing catch-up from very early on. And, I mean, the department did have a series of meetings in early March as well, which, Copney attended along with other groups like AGNI, like the independent healthcare providers, Volunteer Now, different organisations. And, it was very clear at those meetings that the concerns raised about the care home industry were made to officials, and that they shouldn't be forgotten about or seen as secondary to the acute services, given the high risk of people living in care home settings. So that really was the situation in the early stages. There was clearly many weeks where PPE was slow to get out, and while that issue seems broadly now to have solved now for a number of weeks, it really could have been identified at an earlier stage and rolled out more fully. I think what we need to ensure going forward, though, is we need to make sure and not be complacent about the supplies of PPE, that all providers get their stocks replenished when they need them. And we also need to see also as well that where care is being provided in the community, that any carers and domiciliary care workers are also included in that as well.
I don't mean to be rude, but kicking in, but we're told that because time is short, if we don't feel that the answers go in the direction we want, us to come in as quick as we can. That's all very factual, and it's very much the information that we were being provided with as well. I suppose what I'm asking is that you're the Older Persons Commissioner. Did you feel that you were being listened to by the department whenever you were making the representations? Because, we likewise, as a health committee, we heard that there was problems with PPE, we heard there was problems with testings, we heard all of those same issues from the same lobby groups, and then we collectively made those representations to the Minister and others, and then we can determine whether or not we feel we were getting the proper hearing from there. But do you feel, as the Older Persons Commissioner, that people were coming to you, that they were raising concerns, you were going to the department, and the department was taking on board your concerns, listening to what you were saying, and acting on that?
Well, I think if in terms of getting access to the department and the officials, there was no issue with that. When I was able to raise concerns, I got phone calls many times. But in terms of the actions of the department, I have to be honest and say much of the advice that myself and my team was given wasn't taken on board to the level that I would have liked, and certainly wasn't taken on board as quickly as I would have liked. And, there was many times when I did seek answers from the department that it was very slow, the response that we got to issues. So, I think that on certain things the response was quick, but certainly in other areas where I was given advice or asking questions, the response from the department was slow.
Thank you for that, Daddy. Thank you.
Thank you, Colin. And moving on then now to Orlia. Orlia, are you on the line?
Yep. Thanks very much, Eddie, and the panel. So I have two questions I'd like to ask. The first one, Pam had touched on it a wee bit earlier on, just around Eddie. I don't know, have you done any sort of an audit on the number of COVID-related complaints or cases that have been brought to your attention since the beginning of the pandemic? And how many of those have been resolved, or more importantly, how many are pending? That's my first question. And the second question was just in your briefing note, you had mentioned the concerns around the older people that are shielding. And I was just wondering, would your office have any practical suggestions on how the department could better support the mental health needs of those older people shielding, or even if the committee had a sense of, how we could support any practical suggestions that would help our older people in these worrying times. Thank you.
Thanks, Orlia. Perhaps I will go to one of my colleagues in terms of the details of around the number of cases. I'm not sure we have exact numbers, but they'll give you a sense of the cases that are coming through the office. But in terms of just the shielding question, I suppose to answer it first. There's a number of things that we have been doing. Obviously, the calls that we get from older people and their families are very rich, stream of information for us on how older people and their families are feeling about the situation. And many people have been contacting the office, giving their views, which is really helpful. I think the other thing that we established early on was the check-in and chat service for the AGNI. We enhanced that service that the AGNI provide, and many of our staff are also volunteering to be part of that. And that was not just about providing support and advice to older people, but it was really about identifying those people who were shielding, who may be lonely, who may not have contact or have family members. And what we have at the minute is we have a group of volunteers who are having weekly or sometimes twice weekly calls with older people, just chatting through how they're getting on and how they're experiencing. And that's very useful as well in feeding into our work going forward and feeding into the advice that I give government about how older people are feeling and how they're feeling about the future. And that is clearly shown to us, there are deep concerns here. Longer term, we talk about the term the new normal, and I think there's a danger here that while most of us do get back to some aspects of normality, that we don't forget those people who are most at risk, who have to shield longer term. And I think there is a big piece of work here about how we provide support and services, and we may need to start being more innovative in terms of the type of support we provide. We may need to look at things around the social care model. I welcome the Minister's announcement that he's going to review or look at a reform of social care, because it's been my view and the view of many that system has been broken for many, many years and needs to be revised. And what I would call on the Minister to make sure that reform process is as open and transparent as possible and involves all stakeholders, because we have to get that right. We have to look at how we provide support for some of the most vulnerable in our society and get that right. So hopefully, Orlia, that gives you some answer to that question. I'll maybe pass on to Evelyn Hoyle, Chief Executive, or who might come in a bit about some of the casework.
That's great, Eddie. Thank you. Yes, thank you very much, Chair and Commissioner. Orlia, you asked about whether we do an audit of the cases that are related to COVID. Just to be clear, we always log each call or each inquiry according to category, and whilst we can't get into the detail of any of those, we'd be very happy to provide the committee with exact figures. We have had a significant increase in inquiries, and one of the increases that we're noticing, apart from just the number, is the complexity of some of these cases. And it began really with people complaining about being locked out from visiting their older relatives in nursing homes. But it has gone on then to all matter of issues about not knowing what's going on in nursing homes, not being told when there are COVID outbreaks, about being concerned about people coming out of hospital and going into care homes, and then the usual concerns that might arise from what is actually happening to relatives in care homes. We've had some inquiries regarding the community as well. So we'd be very happy to come back to the committee with exact figures on those. I appreciate that. Thank you.
Okay, thank you, Orlia. And going then on the phone to Paula. Are you there, Paula?
Yes, thank you. Thank you very much. Thank you, panel. That's been really, really interesting today, and a lot of the MLAs have asked the questions that I was going to ask. But I wanted to drill down into those people who are at home, maybe have carers coming in, but they maybe don't have shielding letters, but they are vulnerable. And it's really about how they're accessing primary care at the minute, because we know that a lot of them are not going to their GPs and reporting or going to the emergency departments. And I just wondered if you have any thoughts on how we can be encouraging and reaching into the homes, because obviously they're not so much involved in social media, but to try and encourage them to come forward whenever they have other non-COVID related illness.
Thanks, Paula. Yeah, it's a very good question. I think there is a real fear factor out there amongst many older people now, who naturally we will be concerned as as we start easing the lockdown, some will probably rush out the door and get back to life, but there will be many who will be concerned about coming forward, and we've already heard many of the medical family expressing concerns about, a drop in people reporting to accidents, emergency reporting of the normal illnesses and diseases that we deal with as a society. So I think it's a very good question. I am due to have a session with a number of GPs now in the next couple of weeks to discuss the pandemic, and that would be one of the issues that I would be interested in discussing about, because I think a lot of it's about communication. It's about making people aware, particularly those who now are afraid to cross their door and go back out, what precautions they need to take. But I think there is a messaging thing there that clearly has to go out. I think it's something that probably the aid sector as well has a role to play to make sure that older people who maybe experiencing other health issues don't put them, make sure that they act upon them, because we know that there are major dangers if people do delay with certain illnesses. So I think it's a very good question. It's one that I certainly would be interested in getting more involved in. I think some of the deliveries that has been set up in relation during this pandemic have been good as well. The setup we have seen with pharmacies responding maybe to increased deliveries to people at home. But certainly, I think the issue there about people coming forward with concerns about their health is one that, as a society, we need to be clearly communicating that to people, that they must, if they're concerned with their health in any way, whether it's physical or mental, that they should be coming forward to seek that help.
And just as follow on from that then, in terms of where maybe they have a shielding letter, one of the elderly residents had a shielding letter, but I'm very concerned then, obviously, that the partner, their husband or wife, are still there and they're providing intensive caring during this lockdown and the pandemic, and I'm just wondering what we could be doing better in terms of providing respite, when we know that a lot of the norms and reconfigurations have taken place so that the usual systems aren't there. I'm just very concerned, probably links into the mental health, but practically what more could we be doing for carers at this time?
Well, that's always been, an issue for me even before this pandemic. We know that it's been one of the things that I've been keen that we, I think quite often we don't value the work that our carers are doing on a daily basis and the huge role they play in the health system. But they can only do that role if they are supported, and if they look after their own health and are supported to do that. I think you're absolutely right. I think this has probably intensified the role of carers during this pandemic, and I think that has to be part of the strategy going forward, that where people have to shield, we need to be thinking about them and their needs, but also those people who are playing that central role in supporting them as well. So I think there is a big challenge for us going forward in this. There are major issues, not just in terms of mental health, but also in physical health for people who haven't been able to leave the house and really do exercise. And so there's a big challenge for us coming out here that across the government departments, we do need to be looking at the support we provide to people in this situation, and to make sure that we're doing everything possible. And I do think that will be involve us doing things differently. We do need to be looking at this and seeing what other measures can be put in place. One of the things that has been a positive in this pandemic, I know many examples of older people who never were interested in getting online previously, who were maybe forced online by their families when this lockdown came in, and have benefited from that, where we've heard positive stories of people now suddenly every evening tuning in, at dinner time with families and WhatsApping and Skype and all that. And I think that's some of the positive things we've heard about this. And I think the announcement by the Minister earlier this week, where there was going to be an investment into some technology for care homes as well, to use some technology to increase contact with family members is a good step forward as well. But I'm not underestimating the challenges we face here. I think carers are definitely one of the groups that have to be in the priority category here. They're going to be relied upon probably now more than ever before, and we need to be looking after their welfare as well.
Thank you very much.
Okay. So, Jerry, then?
Thanks, Chair. Thanks, Eddie, and your team for your presentation and your work. Since your report into Dunmurry Manor in June 2018, RQIA have taken enforcement action against 3 Runwood care homes. Is there a case for your office to investigate them on the whole as a service provider? Is there also a case that they shouldn't be receiving public money until at least serious changes are implemented? And in 2018, Commissioner, you said that staff in Dunmurry Manor were afraid to speak out. Why is this still the case in 2020? And do you believe that we will still be talking about Runwood homes in 2021 and 2022?
Thanks, Jerry, for those questions. Yes, I mean, you raised some very good points. I mean, I am extremely disappointed that we are 2 years on from Home Truths and we're talking about similar issues in a care home. And, you know, this has been the case for many, many years, and many reports previously where we identified some of the failures and weaknesses in the system. I think the issue of Runwood, the Minister announced earlier this week that he was planning to review aspects of the regulation and inspection system in place, which I think is very welcome. But one of the things the Minister said specifically was he was looking into where there are failings across a number of homes under the one ownership, that's something he wants to look at. And I think it is important that we do that, because whilst at the minute there is more of an individual approach to homes, there has clearly been a number of homes under Runwood where there has been concerns raised, including the shutdown of Ashbrook, Dunmurry Manor and others, and now Clifton. So I think any changes to the system that looks at that in the whole is very important, because clearly one of the things that I have found out in the investigation into Dunmurry Manor and the wider work in care homes is the importance of leadership and management in a care home, and that has to go right to the top. And I think if you get that in place, what you usually find is the care and quality is better throughout the home. So I think that's something that should be welcomed. In terms of public money, I think one of my recommendations in Home Truths was when organisations fail to meet the minimum standards, that there should be tougher financial penalties for those organisations and quicker action as a method of getting those organisations to turn around the care and treatment of people in their homes much more quickly. I think in terms of your final question around complaints, I think, again, that's one of the fundamental recommendations in Home Truths, because what we did see was a nature within Dunmurry Manor of people wanting to raise concerns, and that there wasn't a culture that welcomed complaints, quite the opposite. And I think the people who my office find one of the most valuable sources of information about what's happening on the ground in care homes or different care settings are the people who work in those homes. And the many whistleblowers who have come forward to different authorities, particularly my office, over the last number of years has been particularly useful. But I think really if we're going to see proper change in homes, you know, good homes should welcome concerns, whether those are concerns from staff, whether those are concerns from family members, and a good home should welcome those concerns and address them quickly. And I think it's, you know, the homes that have struggled, you find that they don't have the complaints culture in place that allows people to raise those concerns. So they are some of the fundamental things. They are recommendations within my Home Truths report. And I think some of the stuff we've heard in recent days with Clifton highlights again the need for change. And, you know, one of the things I'll be focusing on, certainly with the Minister of Health, will again be to try to push forward those recommendations as soon as possible.
As well, some of the care homes don't let or don't accept trade unions, which would be a better avenue for people to relay concerns. And just finally, I think we've heard a lot about this being a novel virus, which obviously it is, but my concern is that some of these issues around care homes, around neglect, around discarding complaints and not investigating and putting in fines and measures in place weren't done before this virus emerged. So thanks for that.
Thank you, Jerry. And finally then, Alan.
Thank you, Chair. Ed, I just want to pick up on a few points, a couple of the answers that you give to questions, and then come back to what would have been my original question. In terms of, you've mentioned there that testing, that you can be tested one day and you can be negative, and the next day you could be tested and you could be positive. And obviously the reason that would happen would be because that there would be inadequate infection control within the environment in which you were living. Are you satisfied that the infection control as provided by care home providers at the moment is adequate? The other thing you said, you talked about the acute service has been ramped up in the early days of the pandemic, perhaps at the expense of those in the care home sector. So I'll just ask you, would you accept that the ramping up of acute services was actually done for the benefit of all of society, which would include older people, and indeed in the event of there having been a major surge, that older people would actually have made up the biggest section of patients that would have been requiring acute services. And my own issue, Eddie, is this issue of testing within care homes and nursing homes. And I can understand the reason why people feel that it is the right thing to do. But, I sort of feel that there's a perfect situation, and then there's a reality situation. And it does, it's easy to say, right, put a team into the homes, and you're saying that twice a week you would like to see testing done. I don't know whether you've actually seen or been present when a test has been carried out. I haven't myself. I've just seen the benefit of it being carried out on TV. But it does appear to me to be a particularly invasive and a particularly unpleasant experience. When the swab is put down into the throat, it has to be put down far enough to cause the patient to gag. And it has to remain there for a period of time to get an adequate result. It is then placed, the same swab is then placed up a patient's nose. So it is quite an invasive and unpleasant experience. And I know that there are people in nursing homes, patients who will be able to give their consent. But I'm just wondering, if they have it done once, will they be so amenable to having it done 2 or 3 days later and having it done twice a week going forward for an indefinite period? So that does concern me a little bit. The other concern I have is about those patients, dementia patients, that these are patients who, within the nursing home setting, it may be difficult to get them to take medication. It may be difficult for them to give them food or to have them take drink. So how do we manage that? You can imagine the terror of a dementia patient being approached by a stranger in full PPE gear. So how do we overcome that? Those people are not going to sit there quietly and allow that test to be done. And for the testing within care homes to be, to be effective, it has to be everybody in the home really needs to be subjected to it. So I know that you're speaking as Commissioner for Older People, you're speaking on behalf and saying that yes, this testing twice a week, and that's what you're calling for and that's what you're campaigning for, but taking that section of patients who may, and at the moment there's maybe not anybody complaining about it, but once this becomes widespread, maybe you will start to get complaints from next of kin and indeed from patients. Who is going to speak on behalf of those people, older people, who don't want the test done, or next of kin who decide they don't want this test carried out? Who is going to give them a voice?
Okay, thanks, Alan, for those questions. And yeah, they're very fair questions. I mean, I think in terms of just infection control, I mean, I think that has clearly been the main focus of the RQIA in terms of when this pandemic started. They were repurposed, and one of their key roles was to be providing advice to all the care homes in relation to how they were handling infection control, given how important that is in relation to controlling the virus. And unfortunately, we have heard about Clifton Nursing Home and the problems in that home, but I think that has clearly been identified as one of the key areas that there needs to be a close eye kept on. In terms of your comments around the focus being on acute services and them being ramped up, no, I think you're quite right. I think at the start of this pandemic, we all were very aware of what the threat that was coming to our shores. We saw what was happening in other countries. We saw how health systems were struggling, even good health systems were struggling to cope with the tsunami of cases that were coming their way. So, it was quite right for the authorities to make sure that our health system was geared up as much as possible. And indeed, the messages were going out to society about the steps that we could take to ease that pressure on the system. But nevertheless, I don't believe it was one or the other. I think, we have to view our social care settings as part of the overall health system as well. So whilst it was quite right to get our health and acute settings as best prepared as possible, it was also equally clear of the real threat to older people in care home settings. So I think, it wasn't one or the other. I think it was clearly outlined to the department that this was a group very vulnerable. The stats showed it, and there needed to be more protection put in place at an earlier stage. I think your comments about the testing in homes are good points that you make. I think, it is clear that yes, this process is not can be invasive. But I think it's also important to point out it is a bit of a balancing act here. Yes, it's not something that any of us would want to be doing on a regular basis, but there is a balance of rights here, and I think the right to life and the right to protect life really trumps everything else in this situation. And I suppose that the reality is that many invasive procedures are common in the medical care of our older people, whatever setting they're in. And, if done properly, they can be done compassionately. And, the people that we have in the care homes are professionally trained to deal with the challenges that they face, because some of these challenges aren't new. Many people working in care home settings do face some of these challenges in dealing with people with challenging behaviours who may not understand why they're getting the health support that they're doing. But you make the point, consent is vitally important, and, I think it is important that we do listen not just to the residents themselves, that we do listen to families as well, and obviously we have to be compassionate and do this in a way that people can be comfortable with. So I don't think it's about forcing testing on anyone. I think if there are concerns raised, then they need to be listened to. And I think we do need to be getting the consent of families as well to this. But what I would say is I think the vast majority of the people who have contacted my office in recent times have felt that testing needed to be ramped up. Their primary concern was trying to do everything possible to reduce the spread in the homes, because they have seen firsthand the devastation it can bring. So the points you make are all very well made, and I think they are issues that we do need to consider going forward. But it's not about forcing this on people, it's about doing it with consent.
Thank you, Eddie. And also one just final quick question from me. We learnt yesterday from the Minister that there's a rapid learning initiative being put in place, and we welcome that in light of the necessity to learn lessons very, very quickly here, but also to implement them rapidly so they can safeguard as far as possible against further surges or spikes. Are you involved in that, or do you expect to be involved in that initiative?
I haven't been contacted yet in relation to that, Chair, but I do welcome it. I think any step that takes forward learning from this pandemic is to be welcomed. I certainly would be very happy to communicate with the department and give my view and the view of my team into any initiative like that going forward. I think there's learnings to be made here. There are clearly steps that still need to be taken more generally with our care homes that need to be taken forward. And we all have a role to play to make sure that we're providing the best possible care for our loved ones. Some of them who are the most vulnerable in society going forward.
Okay, thank you. So thank you all for the presentations and your answers here this morning. I too would like to wish you all the best for your second term, Eddie, and I look forward to working with you just as closely as I have done over the course of your first period, and the very important work that you have done, some of which remains outstanding as referenced in terms of the Home Truths report and in terms of the reform of adult social care. Crucial work that we all need to be, and I think all want to be involved in. So thank you, Eddie, thank you, Evelyn, and thank you, Emer. Wish you all, on behalf of the committee, all the best in your work in the time ahead. Thank you for this morning, and we look forward to meeting with you again soon. Thank you.
Thanks very much, Chair, and thanks to all the committee members. Thank you.
Thanks. Okay, members. Thanks for that. I will propose now we take a short break so that we can come back to our next item. We'll maybe take a 20-minute break there, and then we'll forgo a lunch break in order to try to get business completed to allow members to attend other meetings which are taking place this afternoon. So could we be back here for 12:15? Okay. Thank you, members. Okay, thank you, members. We're resuming our meeting now, and the next item on the agenda is SR 2020/57, the Mental Capacity, Deprivation of Liberty Amendment Regulations 2020. And I refer members to your papers there at tab 6 of the pack. I can advise members that the Department has made a statutory rule to make temporary modifications to the principal Mental Capacity, Deprivation of Liberty regulations in the case of the widespread unavailability of the health and social care workforce due to a pandemic emergency. Such modifications include requirements around training, experience, the make-up of trust panels, the authorisation of detentions, and the definition of a responsible medical practitioner. The regulations modify who can do certain duties, but impose a reporting requirement when those modifications are used. Can I remind members that the committee considered the SL1 on the 26th of March and, given the urgency of the situation, agreed that it was content that the Department make this statutory rule. We also agreed that we would want to review the suite of coronavirus SRs in due course. The Department advises that there has been no change to policy content since the SL1 was submitted to the committee, and that key stakeholders have been consulted and are content. The regulations came into force on the 2nd of April and are subject to negative resolution. The Department advises that they remain in force only so long as Schedule 10 of the Coronavirus Act is in operation. The Examiner of Statutory Rules has reported that the regulations were made in breach of the 21-day rule, but that she is content for the Department's reason for this and has no other issues to raise. I can also advise members that a departmental official is here today to respond to any issues members may wish to raise in relation to the regulations. I would now like to welcome Mr. Thomas Adele, Head of Mental Health and Capacity Unit within the Department of Health. So I'll have a question or two myself, and then I'll go to members for questions. You're very welcome here this morning, Thomas, and thank you for coming along to our meeting. I suppose my first question, Thomas, in relation to this, and given that this is a serious area of concern, but also recognising the impending situation that prevailed at that time, but it's linked to the Section 10, or Schedule 10, sorry, of the Act. How long will that Schedule 10 be in operation? Can you highlight explain to the committee how long Schedule 10 will continue to operate for, or in what circumstances it will be removed?
Sure. I mean, as you're aware, the whole Coronavirus Act is subject to reviews in Parliament, and it's a maximum lifespan of 2 years. On top of that, we are continue reviewing what's happening with regard to Deprivation of Liberty in the trusts, to see what the pressures are like and see how the powers are being used or amendments being used. We're doing that on a roughly 4 weekly basis. We had the latest review last week and beginning of this week when we got some figures back for usage. So we're seeing if we should stand down the powers or we should keep them going. There are some aspects of the powers in the Coronavirus Act which is linked to, which we definitely want to keep going. That includes remote working, for example, what is not permissible under the Mental Capacity Act, but is permissible under the Coronavirus Act. When it comes to these regulations, they are reducing the safeguard or the professional requirements among people involved in the Act, and they're not heavily used. So we are currently considering how we best take this forward to make sure we provide optimum safeguards for people who lack capacity. At the same time, make sure that they can avail of the safeguards, because if we don't have enough professionals, we can't have any safeguards at all. So it's getting that balance right. It is something we take very, very serious, of course. I mean, we've said from the very outset that the human rights of the people are the key thing, but we need to balance the Article 5 rights, the right to liberty, the Article 2 rights, the right to life, to make sure we get that right.
Okay, and you've said there that there has been a record kept of how many times this has been used. So can you tell us how many times it's been used in relation to both those areas, or in relation to any of the areas within them? How many times has it actually been used? So
I don't have the numbers for the Coronavirus Act, I only have the for regulations. And at this point, the Trust only report used them twice, which does indicate there's not a strong need for the regulations at the moment. We only got those figures in yesterday, so we had the time to go into them in detail and discuss what it actually means. In the Coronavirus Act, the remote working, we know that's the standard for the Trust panel operation, so that is being used all the time at the moment. The other part of the Coronavirus Act in itself, I don't have those figures at hand at the moment, because that's review is ongoing as we speak.
Okay, and can you get us those figures then? And in relation to the remote working, how are you checking that people, first of all, have access to the equipment and the broadband that they need, but also that the additional communication difficulties are being addressed within the remote working? How is that safeguarded against?
It's through the Trust normal procedures. So the Trusts are providing strong assurance reports that they are doing this safely. The Trust panels have also been instructed, the Trust panel members have been instructed that if they're not comfortable with the decision making of remote working, they should not make decisions working remotely and demand the panel in person. The remote working can only happen if there is unanimous agreement on the decision. If there are disagreements, they're not allowed to make a decision remotely. So there's an extra safeguard built into the Coronavirus Act itself to make sure we safeguard the people who need to be protected.
Okay, thank you. I'm going to go across now to our Deputy Chair, Pam Cameron. Pam.
Thank you, Thomas, for being here to answer questions. I just want to ask you what steps will be taken to inform staff of the impact of the modifications in order to ensure they're harnessed and exercised where necessary.
So all the trusts have a director who's responsible for Mental Capacity Act, and also to have an implementation lead, as we're still in the implementation phase of the Mental Capacity Act in the first place. So we've been communicating with those contact people in the trust and been asking them to share this across the trusts. In addition, we've developed a code of practice for the modifications, which have been shared with all their stakeholder lists we have in relation to the Mental Capacity Act. And the code of practice sets out, it's a temporary code of practice for coronavirus modifications, both in the Coronavirus Act and in the regulations. And that sets out how this thing operates in practice, including some, what we believe will be fairly easy to read table forms to set exactly what it is they do.
Okay, I'm going to check, I'm going to Jerry here, and then I'm going to go to the phones to the members in the order in which I checked you in for this session there. So that'll be Paula, Orlia, Pat and Colin. I'll just check if you have questions. If you don't, that's fine, but I don't want to miss anything either. So I'll go to Jerry and then I'll come across to the phones.
Thanks, sure. Thanks, Thomas, again. I think I don't want to misquote you, but you sort of alluded to maybe safeguards not happening if there's a problem or lack of professionals in place, and I think there could be concern about that. We had a briefing about another statutory rule or an SL. I think there was a concern raised about that, and maybe staffing being an issue rather than maybe regulations being required around the child protection issue. But yeah, you said it was used twice. I mean, obviously you can't give confidential information, but can you give a general sense of why it was used? And also, I'm just checking, there was a legal challenge in England. I think I referenced it the last time you were up in the committee, Thomas, and I think it's pertaining to the best interest meetings, challenging that aspect. Is there a concern that parents or adults or people in families aren't attending those meetings, and they may be excluded, and sort of the full scenario of the person involved, sort of day-to-day life or living, isn't being reflected? And I'm not disputing the professionalism of people and the workers, but I think there's an element of concern, certainly in England, about the best interest meeting. So could you maybe address that if you can?
Yeah. Keep them right there for me something.
Okay.
So,
sorry.
Firstly, the regulations changes the professional requirements among some of the safeguards. It doesn't remove the need for professionals. It changes the requirements in relation to experience and training. If you don't, and for one thing, membership of a Royal College, which is required for short-term detention and medical reports. If we have those requirements and we don't have people available because of absence or sickness, whatever absence, the law doesn't allow anyone else to carry out the functions. So by removing those specific requirements, we're widening the pool of people who can carry out the functions. So that's what I mean with, if the regulations are in place, we feared in March at least that the safeguards wouldn't be carried out because we wouldn't actually have the professionals available to carry out the functions. So but we've been widening the pool to make sure the safeguards are still available, and we're still using professionals. So it's not that we're saying that people who have no knowledge of these kind of issues should carry out these functions. The only areas that has been used is short-term detentions and requirements of membership of Royal College, and the requirements of trust panel members to be 3 different professions. That's the only 2 areas where it has been used. And that's arguably areas where we are less concerned than, for example, carrying out formal assessment of capacity, because that's a core function of the whole process. That's kind of the starting point that kicks off the thing. And those things have not been used. We shouldn't forget these were planned in March, these were made in March, when we were fearing a much, much worse situation than what happened. Thankfully, I think we can all be very thankful that it hasn't been as bad as we feared at one point. So staff has been available, and that's where we're considering what the next step should be. We also made it very clear if they can use the normal professionals, they should use those, and this is only last resort. In addition to best interest, the best interest decision is crucial to getting decisions right. The primary legislation said that all relevant people must be included in decision making. It doesn't specify who they are, more than it's relevant people, and then lists indications who they are. We have not changed who that is. If there are family members that it's practical and appropriate to speak to, they must be spoken to. We have not removed those because that would undermine a significant part of the whole decision making around Non-Capacity Act and Deprivation of Liberty. How you speak to them, that's up to professionals. That's not provided in the primary legislation. So that can be done remotely. They can be done through video conferencing, through phone calls, or it can be done in person if it can be done safely in accordance with other regulations, of course. So that safeguard is still in place, and we certainly do not want to remove that safeguard. We have no intention of limiting, reducing the interaction around best interest.
As far as you're aware, has there been any issues raised since these regulations have been put in place about the best interest meetings in particular?
I'm not aware of anything. So nothing has come to my attention or the department's attention.
Thanks.
Thank you. Going now to the phones, and I'm checking in first of all with Paula. Do you have any questions for Thomas on this section, Paula?
No, thanks, because the question was just covered at the tail end of the last comments. And thank you, no.
Thank you. And going then to Orlea. Orlea, do you have anything you wish to ask in relation to this?
Yeah, I was finding it hard to pick up the sound quality of Thomas speaking points there, but I think he was saying that, well, Jerry Carl had said that he had mentioned the order was used twice. So I'm just wondering, Thomas, is the department considering whether the SR is still necessary on the basis of, was there maybe not the staff shortages that you had been preparing for, so you haven't had to use it as frequently maybe as you thought you might have done?
Yes.
Speak directly into the mic. You might pull the mic around.
My apologies. I know I have an accent and I know I speak very fast as well. So many apologies for not speaking as clear as I could.
No, I think it's just the phones. I think we can understand perfectly. So it's the phones.
No, I'm very used to that. So, no, I mean, it hasn't been as bad as we were fearing. And I think that's across the whole health service, as I'm sure you're fully aware, or very aware of. So we are certainly considering what the next step should be. I only got these figures yesterday, so we haven't the time to look into them in detail. But I mean, certainly one of the options would be to stand down the regulations to revoke them because they're not needed. At the same time, we want to make sure that we're prepared for any future surges, so we don't put ourselves in a position where we're in a really bad place. And I mean, it becomes a balance between not reducing the safeguards unnecessarily and at the same time make sure that the staff are available to carry out the safeguards. And it's a very difficult balance when it comes to considering human rights. It's a very important issue. I mean, we're quite passionate about getting that balance right. And looking at the figures now, there's clearly a stronger case for revoking the regulations than there were before we had the figures. But as I said, I only got the numbers yesterday, so I would have to come back to committee when we had time to look at them and speak to the trust and getting proper feedback.
Okay.
Thanks very much, Thomas.
You okay with that, Orlia?
Yes, thank you, Chair.
Checking in then with Pat to see if you have any questions, Pat, on this.
Chair, all the questions I had have already been answered.
Yeah, I'm happy enough. Thank you, Chair.
Okay, thank you. Just a final one for me, Thomas, that occurs to me as we speak. You said there that these only are to be implemented or used where they're necessary. How do you monitor that out at trust level that is the case, that's what's being done?
Well, I mean, we're asking the trust to keep a track of what they're doing to keep us up to date with what's happening, and that's why we got the numbers we got this week. So that's how we're doing that. Okay,
thank you. Well, I think we can allow Thomas then to carry on with your day's work. Thomas, thanks for coming along to the committee.
Thank you very much.
Once again, good to see you as always, and all the best for now. Thank you with that.
Thank you very much.
Okay. Okay, members.
Thank you.
So if that's any further points or anything, members, before we move on to formal consideration? Okay. Can I ask members then to formally agree that the Committee for Health has considered SR 2020/57, the Mental Capacity, Deprivation of Liberty Amendment Regulations NI 2020, and has no objection to the rule? Are we agreed?
Agreed.
Agreed on the phone as well, yes. Thank you. Thank you, members. Moving on then to Section 7, SR 2020/60, the Establishment and Agencies Fitness of Workers Regulations NI 2020. I refer members to tab 7 of your pack there. I can advise members that the Department has made a statutory rule to make temporary changes to pre-employment vetting policy for health and social care roles. This has enabled employers to start a worker in advance of full pre-employment vetting, but subject to certain conditions, including supervision. This is to ensure that pre-employment vetting does not cause undue delay in recruiting staff urgently to health and social care roles, to cover for significant COVID-19 related staff absences and additional workload. The Department advises us that proof of identification and registration with regulatory bodies, where applicable, is still required, and that individuals will be supervised until all specified pre-employment information is received. Can I remind members that the Committee considered the SL1 on the 26th of March and, given the urgency of the situation, agreed that it was content that the Department make this statutory rule. The Department advises that there has been no change to policy content since the SL1 was submitted to the Committee. The regulations came into force on the 2nd of April and are subject to negative resolution. The Department further advises that although there was insufficient time to consult fully on the SR, the proposal was shared with key health and social care stakeholders, and there is broad support for this temporary legislative change. Members may recall this relaxation of rules was something the Independent Health and and care providers had called for, and Pauline Shepherd advised us here in the committee that it has been helpful. The Examiner of Statutory Rules has reported that the regulations were made in breach of the 21-day rule, but that she is content for the Department's reason for this and has no other issues to raise. I can advise members that the departmental official is available to respond to any issues members may wish to raise in relation to the regulations. Do members have any issues with this regulation that they wish to raise with departmental officials? Nothing in the room. What on the phone there, members? Are you content, or do you wish to raise issues with officials? Members are content, I think, on the phone?
Yes.
Yeah. Sure. Okay. Thank you, members. In that case then, can I ask members to agree formally that the Committee for Health has considered SR 2020/SR 2020/60, the Establishment and Agencies Fitness of Workers Regulations NI 2020, and has no objection to the rule. Are we agreed? Agreed. Thank you, members. Moving on then to item 8, Legislative Consent Memorandum, Medicines and Medical Devices Bill. I refer members to tab 8 of the pack and tab 8 of the table papers. Do we need to take a short break to get the... So, members, my apologies, I'm going to go back slightly. We do need to take a short break to get Ms Cathy Harrison and Mr Craig Allen in to brief us on this legislative consent motion. So we're going to take a very quick 2 or 3 minute break here just to arrange that. Thank you.
Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30.
Okay, members, we're back in public session. We're just going to, I'm going to suggest that we move on to item 9 while we get the officials from the department on the line for item 8. So I'm suggesting if the members are content, we'll move on to item 9 and return to item 8 when we get the officials on the line. Are members content with that? Yeah, thank you. So item 9 is the Domestic Abuse and Family Proceedings Bill, consideration of draft report, and I refer members to tab 9 of the pack. Can I remind members that the Committee for Justice asked this committee for its views on the Domestic Abuse and Family Proceeding Bill by June 5th. Following last week's evidence session and committee deliberations, a draft response on the bill has been prepared. So I'd like to, that's a tab 9 of your pack there, and I'd like to ask members, do they have any comments on the draft report?
I think it reflects sort of the various sort of concerns raised. Sure, you know, people have different issues, and I think it reflects most of those. So,
yeah, thank you. On the phone, members, are you content with the draft report? Yeah, I'm hearing no objections.
Yes, content, Chair.
Yep, thank you, Pat. Paula.
Sorry, Chair, can I come in, please?
Yes, go ahead.
Thank you, and thank you for the report. It was very good. Committee Clerk, it was just in relation to clauses 8 and 9. As people know, that clause 9 is regarding using children as an aggravator, and I'm not sure that I think there should have been an additional recommendation in there, the one that I have raised around providing guidance to the social workers who may be the frontline responders, where the domestic abuse is taking place, and then the children have to be interviewed to see whether they have been used as aggravators. And it was really around the guidance for the social workers so that they can recognise what that abuse would look like in reality, you know, around the abusive text to the other partner and stuff. So I just think that that's missing from the report in terms of that being used as an aggravator in the abuse.
Okay. Are members content? Would you be able to draft that in, Ailish, and come back at the end of this section or at the end of the meeting, or how do we? Because we do need to get this.
If members are content, we could get it agreed by email. I'll draft in the amendment and circulate it by email for agreement.
Members content with that? I would also like to propose a slight amendment to recommendation 5, just to say that this approach, and that's the recommendation on where it was flagged up that there was issues around the criminal justice element of this, and I was asking that this approach should be in line with existing youth diversionary justice principles, that where a young person becomes an offender as well as a victim, in the sense that diversionary approaches would still be open to them. Are members content that that is amended slightly? Yep. Okay, so members are content then that a further amendment based on those 2 points will be made and circulated to members for final approval. And
that'll need to be by tomorrow, if that's okay with members.
Just to meet the timelines, that needs to be by tomorrow. Okay, members content to address that. Okay. Can I check now back again on the phone line? Do we have officials from the department? Kathy Harrison, are you there, Kathy? Kathy, do we have anyone from the department there? Kathy Harrison or Craig Allen?
Hello, hello, Chair. It's Kathy Harrison and Craig Allen from the Department of Health.
Okay, thank you both. So, members, now as agreed, we will then revert to section 8, which is the Legislative Consent Memorandum, Medicines and Medical Devices Bill. I refer members to tab 8 of the pack and tab 8 of your table papers. And can I advise members that officials from the Department of Health are here by teleconference to brief the committee on the legislative consent motion led by the Minister of Health in respect of the Medicines and Medical Devices Bill introduced in Westminster. And I would now like to welcome Ms Kathy Harrison, Chief Pharmaceutical Officer, and Mr Craig Allen, Head of Medicines Policy. You're both very welcome to our meeting this morning, and thank you for coming along to brief us on this LCM. And I would now like to invite you to go ahead and brief the committee, please.
Thank you, Chair. Thank you for the opportunity to brief the committee today on the Medicines and Medical Devices Bill, with particular reference to those provisions of the bill that deal with human medicines. At the outset, it might be helpful to provide a bit of brief background and context, which will help explain the purpose of the bill. So when the UK joined the European Union in January 1973, one of the conditions for EU membership was that the UK was required to give effect to EU law in the UK. This was achieved through the European Communities Act 1972, which provides for EU regulations to take direct effect in UK law. Section 2.2 of the European Communities Act also provides a delegated power by which EU directives and other legislation can be transposed into UK law by means of domestic regulations. The decision taken by the UK in June 2016 to leave the EU has led to a number of pieces of legislation, such as the European Union Withdrawal Act 2018, and by operation of Section 1 of that Act, Section 2.2 of the European Communities Act 1972 will be repealed. However, the European Union Withdrawal Agreement Act 2020 has inserted a new Section 1A into the European Union Withdrawal Act 2018, which will save and amend the European Communities Act 1972 so that it continues to have effect in UK domestic law during the transition period. So, in relation to the regulation of medicines, medical devices, clinical trials and veterinary medicines, this has been a matter of EU competence since the UK joined the EU. The EU has legislated in each of these fields and created comprehensive regulatory frameworks in each case. The comprehensive frameworks are established in EU legislation and in terms of human medicines have primarily been implemented in the UK by the following legislation: the Human Medicines Regulations 2012 and the Medicines for Human Use Clinical Trials Regulations 2004. As I've indicated earlier, Section 2.2 of the European Communities Act 1972 has been used to make changes to these regulatory frameworks. However, at the end of the transition period, Section 2.2 of the European Community Act 1972 can no longer be used to make changes. For that reason, there is a need to have legislation in place which will allow the existing regulatory frameworks to be updated or amended by means of subordinate legislation. Without the existence of equivalent delegated powers, the UK Government and Northern Ireland Assembly would have to rely on primary legislation to make any changes to the regulatory frameworks. So the Medicines and Medical Devices Bill seeks to provide the necessary delegated powers that can be exercised to make changes to the current regulatory regimes. To that extent, it is essentially an enabling bill, insofar as it provides the delegated powers to allow changes to be made to the regulatory regimes by means of subordinate legislation. So specific features of the Medicines and Medical Devices Bill in relation to human medicines are that Part 1 of the Medicines and Medical Devices Bill, which is clauses 1 to 7, create the necessary delegated powers which enable specific features of the regulatory regimes for human medicines and clinical trials of human medicines to be updated by subordinate legislation. Clause 1 of the bill confers a delegated power to amend or supplement the law relating to human medicines, which is defined at Clause 7 of the bill to include 4 pieces of legislation only. And these are the Human Medicines Regulations 2012, the Medicines for Human Use Clinical Trials Regulations 2004, the Medicines Act 1968, and the Medicines Products for Human Use Fees Regulations 2016. It is worth noting that Clause 1.2 places a duty on the appropriate authority making the regulations to consider 3 factors before doing so, and they are the safety of human medicines, the availability of human medicines, and the attractiveness of the relevant part of the UK as a place in which to conduct clinical trials or supply human medicines. From a Northern Ireland perspective, the appropriate authority is defined at Clause 1.4 as the Department of Health. Clause 2.1 lists matters relating to the manufacture, marketing and supply of human medicines that regulations made under Clause 1 can address. The list at Clause 2.1 is exhaustive and includes such matters as authorisations to manufacture human medicines, the registration of the premises of pharmacy businesses, the recording of information about the supply of human medicines, advertising with regard to human medicines and the registration of persons who supply or offer to supply human medicines by means of the internet. And then moving on to Clause 3. Clause 3 of the bill deals with falsified medicines and lists matters relating to two things that regulations made under Clause 1.1 can address. They are, the first is the prevention of the supply of falsified medicines, and the second is enabling any information that is collected for the purpose of the prevention of the supply of falsified medicines to be used, retained and disclosed for any purpose to do with human medicines. Clause 7 defines falsified medicines as human medicines that represent falsely their source, provenance or identity, including packaging, naming or composition. Clause 4 lists matters relating to clinical trials that regulations under Clause 1.1 may address, and again the list is exhaustive and includes such matters as the notification and reporting requirements in relation to clinical trials and requirements that must be met before a clinical trial may be carried out. Clause 5 provides regulation making powers that deal with fees, offences and powers of entry and inspection. Clause 40 requires that before any regulations are made, there has to be consultation with such persons who are deemed appropriate. The only exception to the requirement to consult relates to regulations which will be made under Clause 6 of the bill, and they are in circumstances where a regulation is required urgently in order to alleviate a threat of serious harm to the health of the general public or a section of the public. And Clause 41 deals with procedures for the regulations and provides that, subject to certain exceptions that are listed at Clause 41.9, any regulations made by the Department of Health under Clause 1.1 will be subject to the draft affirmative procedure of the Assembly. So the legislative consent motion is needed because both the human medicines and veterinary medicines are transferred matters and, as such, fall within the legislative competence of the Northern Ireland Assembly. A legislative consent motion is therefore required for these provisions within the bill. Responsibility for matters relating to human medicines fall under the responsibility of the Department of Health, whilst those that deal with the veterinary medicines fall within Clauses 8 to 11 come under the remit of the Department of Agriculture, Environment and Rural Affairs. Those provisions within the bill that relate to medical devices, Clauses 12 to 37 and Schedule 1, are reserved matters and as such lie outside the legislative competence of the Northern Ireland Assembly. So as the bill deals with transferred matters relating to two departments, it has been agreed that the Department of Health will take the lead with policy input from DAERA. On the 1st of April 2020, Minister Swan circulated a paper to provide the Executive with background and information about the purpose of the Medicines and Medical Devices Bill, and the paper also sought Executive agreement in principle for an LCM for those aspects of the bill that deal with transferred matters. The Executive paper was subsequently agreed by the Executive at its meeting on the 22nd of April 2020. On 1st of April 2020, the Minister also wrote to the Chair of the Health Committee to provide information about the purpose of the Medicines and Medical Devices Bill and to advise about the need for a legislative consent motion. The current position is that the Medicines and Medical Devices Bill was introduced in the House of Commons on the 13th of February 2020 and passed its second reading stage on the 2nd of March 2020. It has been referred to a public bill committee for scrutiny, and it is anticipated that it will reach its reporting stage during week commencing 18th of June. And Chair, thank you. That's the end of my formal report.
Okay, thank you, Cathy. So, members, the next stage is for us to formally consider if we are content to support the Department in seeking the Assembly's endorsement of the legislative consent motion. So I just want to ask then members, are there issues arising or are there questions that you wish to put in relation to this? I have one indication and I'll come to the phones. I have two indications now, I'll come to the phones in a minute. But before we go to the members there, Cathy, you had mentioned in the middle of your presentation a number of acts, I think, that were, or a number of areas that were specifically impacted. HR, I had noted that HR regs, clinical trials, Medicines Act and products. So this is fairly significant in terms of the scope and scale, and in light of the withdrawal agreement and in light of the cross-cutting nature of clinical trials generally, how do we protect our involvement in wider European clinical trials and also in maintaining cohesion north-south in terms of manufacturing medical devices and products, and that we don't fall out of the protections that have been offered by the withdrawal agreement? So can you explain that to me, how this meets that requirement?
First of all, Chair, you're correct. The scope of the bill is extensive, and it is necessary in that it provides us with the ability to continue to make changes to these regulations after we finally leave the EU formally. And these are active parts of legislation as well. So I'll give you an example. The human medicines regulations would be, regularly updated on a sort of rolling, sort of twice a year period, and the type of things that brings in and enables is for us to make decisions about the type and range and scope of prescribing practice, and it has supported in recent years, for example, the introduction of non-medical prescribers such as pharmacists, nurses, physiotherapists, etc. So these are very important. It's very important that we have the ability to maintain changes in line with what we need to make changes with in terms of the HSC. Moving on to the issue around clinical trials and wider issues around the EU exit. We are working very closely with GB in terms of, and particularly with DHSC and MHRA, the Medicines Healthcare Regulatory Authority. And for medicines, we are very acutely aware that we want to ensure that we reduce the risk of any divergence between ourselves and GB that may arise following EU exit. Issues relating to clinical trials will continue to be managed by MHRA, and my understanding is that the intention is that will be closely, that a close link with the EU will be maintained there. Chair, a lot of this is still at early days, but that would be the high-level aspiration there. And the issues around supplies of medicines and access to medicines are all part of the work that we're doing currently in preparation for implementation of the Northern Ireland Protocol. So there are considerations there around impact on supply of medicines and access to medicines.
Yeah, and I note your concern around the danger or the issue of divergence across the water. But what about the issue of divergence across Europe and particularly north-south? And I know it says in your conclusion, the view of the Minister of Health is that in the interest of good government and consistency across the UK, insofar as the provisions of the bill that deal with the devolution matter, they should be considered. But what about the fact that the withdrawal agreement is designed to ensure that we do not diverge from what's happening within the south? And this is a very, very major area of both health but also industry as well. So what protections have been put in place to protect to ensure against divergence north-south?
The protocol requires the application of certain EU technical regulations and directives in Northern Ireland, and many of those apply to medicines, Chair, and that they are designed to ensure that divergences the risk of divergence is avoided. So I don't see the risk in terms of north-south divergence in particular being an issue, although we are alive to all risks at this moment in time. But at this moment in time, the divergence that we see more of a risk is GB and Northern Ireland, where Northern Ireland would still be quite closely aligned with EU.
Okay, but I took it from the start of your presentation that you had said that this has been competence within the EU, and that now this would be a move away from that. But why would the EU not have grave concerns in such a serious issue if there was divergence that they would have? How would the EU sign off on what we'd be doing in the future based on this? How would the EU satisfy themselves that it didn't present any difficulties for them?
I suppose we need an understanding of what we're talking about in terms of divergence, Chair, because there's quite a lot of complex issues here. There's some of the issues that I referred to there, such as prescribing rights, etc., are distinct to UK and always have been. Some of the issues around divergence that I refer to are more relating to the licensing of medicines and introduction of new medicines, for example, and also some requirements around the regulation of medicines in respect of Falsified Medicines Directive, where Northern Ireland will still be expected to comply with EU, whereas GB are not required to comply, and there is a risk of divergence. With no evidence there will be divergence, but there is a risk in time of divergence there.
Okay, thank you. I'll go across to members, Jerry and then Pam.
Thanks, Chair. Thanks for the presentation, Cathy. My understanding of the bill in England and the UK is that it'll basically allow the government to take over the rule book for human and veterinary medicines. I'm just unsure in my own head what role the Department of the Minister plays in that. Is it all devolved here with the LCM, or is there certain aspects that are still controlled in London? And in regards to the changes to the regulations and clinical trials, is there any scope, or does this allow for the possibility of trials around things like cannabis-based medicine, or is it specific to specific types of medicine? Thanks.
It will apply to all trials, and that would include something like a cannabis-based medicine if it was undergoing a formal clinical trial. And I'm sorry about this. Could you repeat the first point?
Yeah, just in regards to, essentially the UK government, my understanding you makes the decisions going forward now around human and veterinary medicines. Is it everything in relation to that devolved here, or is there parts that are devolved, parts are maintained by London?
The human medicines regulations, for example, are co-signed by our Minister of Health. So we're very, very closely involved in any changes to any aspects of these areas of legislation, and always have been, and we will continue to be. And they're subject to for-country consultation.
So just so I'm clear, sorry. So it's decided in London, but we have an LCM in regards to any future changes. Is that the case?
Future changes in respect to this. Craig, do you want to say?
I think all this would really do, Mr. Carroll, is allow, whilst Westminster are legislating on what is a devolved matter, the purpose of this is really just to give us a power to make some of those changes that we will need to make through subordinate legislation here. It's just simply, it might have been possible to do our own Northern Ireland bill, but just the fact that we were included in this, we've had an opportunity to have what our devolved competences are involved in this bill, are included in this bill, and therefore the Assembly are just giving, essentially all this is doing is the Assembly is just giving Westminster the authority to legislate on what is a devolved matter. It's really no more than that at this particular point in time. We would obviously make any changes ourselves to the regulations through subordinate legislation, and obviously those regulations would be scrutinised by yourselves and by the Assembly if necessary.
Thanks.
Thank you, and thank you for your presentation. I think, my question was kind of similar to Jerry's. So I think what he was trying to ask was what powers do our local ministers have in these areas, and if they do have powers, how they intend to use those powers. And also, are there areas of EU law that we could do better?
As I say, I think really, hopefully I've maybe covered it in the answer to Mr. Carroll, in the sense that yes, human medicines and veterinary medicines are devolved matters, but just for the purposes of this particular piece of legislation, we have been asked to give Westminster the authority to do that on our behalf, and obviously the Assembly will need to take a vote on that at a debate in the Chamber. I'm not necessarily sure about us doing better. I'm not quite sure, Ms. Cameron, about us doing better than EU, in terms of EU in certain bits of legislation, but certainly we have, in terms of human medicines and veterinary medicines, we have the power to make our own regulations here. Still, when we'll include it, that will stay with us. That power will still be with us to do that.
Okay. So, do we know if there's any intention to use those powers from the Minister?
At this stage, I'm not entirely sure. As I say, it's very much a power that is there to be used, but at this stage, I'm not sure whether there's any intention to use it or not.
No. Okay, thank you.
Thank you. I'm going to go now to the phones there, in the order that people came into this session, or they checked people in this session. So I'll go first there to Paula. Are you on the phone, Paula, and do you have anything for officials, questions? Okay, I'll check back with Paula again in a minute. I'll go now to Orlia.
Hi, Chair. Yes, I was just wondering, has the DAERA committee had sight of this then? Because obviously, it there's an overlap there with their departmental powers as well. Or do we know if their committee has came to any views on it or done any sort of written report on it or comments?
They will certainly be aware of it. They should be aware of it in the sense that I think once the memorandum is laid at the business office, as my understanding, would distribute it to the appropriate committee. So, as far as I know, certainly I think officials have previously briefed the committee about it, but whether they've come to any conclusions, I'm not entirely sure.
Okay, yeah, I can just advise that the committee, the clerk has advised the Department of Agriculture and Rural Affairs around that. It has drawn their attention to it, the veterinary medicines part of that. Okay, Orlia, anything else there from you?
No, thanks, Chair.
Okay, I'm going to go then to Pat on the phone.
The only issue I would have concern about, the Chair, is when do we have to make a decision on this?
Let me just take some advice from the clerk on that, Pat.
Well, officials will maybe correct me if I'm wrong, but I was expecting that the committee would really have to primarily do its deliberations today. I would draft up a report for approval by the committee at the next meeting. But if we hear that Westminster's moving faster, I may have to try and get members' agreement by email. But based on what we were told this morning, that it's most likely to report week beginning the 18th, hopefully we could sign off our report next Thursday and try to get any clarifications in between times.
Okay, so we could draft the report based on our considerations today, defer a decision, and come back to the decision at next week's meeting.
In any case, you would want to approve the report drafted on your behalf.
Okay. Are you satisfied, content with that, Pat? Is that clear?
I'm happy that we don't have to make a decision today. I think it's a good idea to defer it, maybe for a week anyway.
Okay.
Thank you.
Yeah, okay, Pat, thank you. So I would just like, Kathy, sorry, I'm bringing Eilish back in there.
Sorry,
Clerk of the committee.
Sorry, just to be clear, as far as possible, it would be helpful to have members' views, instructions to me as to what they would like the report to contain today, but obviously that would be pending formal sign-off, so members wouldn't be bound, but could give me a preliminary sense of their views today, subject to clarifications and subject to seeing the report next week.
Okay, I would like to ask Cathy there a question in relation to, you have said, Cathy, that there are some areas governed by protocol, the withdrawal protocol, and some where we could diverge from the EU. Can you give us some indication of what would be within both of those categories? Which would be covered by the protocol and which would be potential to diverge?
There's a general risk related to the protocol around divergence, and that is where if regulatory or decisions around medicines regulation, if GB begins to diverge from the EU. Up until now, we've all been aligned with the EU, and that means that there's an equity in terms of our understanding of regulations and our compliance with them. After EU exit, there is no longer a requirement for GB to comply with EU regulations in respect of medicines. And I do want to stress the fact that this is complicated and we're working through a lot of these issues at the moment, Con, so I'm not able to give you a comprehensive line by line at this stage, but we are moving towards that. At this stage, the risk is that decisions could be made, which would mean the GB, in theory, could diverge from EU in areas that Northern Ireland would not be able to diverge from EU on, and that would then create a difference in terms of perhaps access to medicines between Northern Ireland and GB.
And do we have any assessment, Cathy, of what the situation in the south is in relation to? So it's not only complicated, but it's also worrying in the sense that there's a lot of people, say, along the border corridor who would have a GP on one side of the border and maybe pharmacy on the other side, or vice versa. Is there any assessment of what the impact on that area would be, or how that would be managed in the event of divergence?
In the short term, I think I think at this moment in time it would be fairest for me to say we need to look into that again. Obviously, we looked at all of this ahead of the January exit date, and we were confident that we had addressed and mitigated against all of those risks. I don't see necessarily divergence as being an issue there, Chair, but that in terms of that north-south prescription supply area. So not immediately, but we would need to be looking into it as part of our wider work on this.
I suppose one thing that has happened since January is the COVID-19 pandemic has kind of highlighted the cross-cutting nature of viruses and the fact that systems and need to be ready to cooperate across borders to ward off some of the impacts of some of these things. So I suppose that has focused the minds. I have to say I'm struggling a bit to understand the scale of it and to be comfortable with it. I have to say, just how significant this could be is quite concerning. You'd mentioned other aspects of the bill. You'd said there was other aspects of the bill where the North here could diverge from the EU. Can you identify those areas or supply those to the committee?
I think that I've just returned to my previous point. It's mere the area of main area of divergence is in relation to the regulation of medicines and the licensing of medicines, and at this moment in time, Chair, and I mean the risk. There's no evidence there will be divergence, but we're just flagging that there could be divergence in terms of the arrangement.
And are there areas of this bill that aren't covered by the EU?
No. This is no. This all areas in this bill would have previously been covered by the EU Act.
Okay.
Without, maybe just without these changes, we will be in a position. Craig, do you want to say without making these changes?
I suppose without having been included in the bill, any changes that we would have to make to regulations would have to be done through the primary legislation route. All this is really doing is giving us the power to make some changes through subordinate legislation. If we didn't have the power, then some of the changes that we'd be required to make that we would have normally made through subordinate legislation, we would have to make through the primary legislation route, which would be, as you can understand and members are aware of, the various stages and the extensive and intensive nature of a bill going through the Assembly.
Okay. Is there any other questions from members before we deliberate? I'll let Cathy and Craig go, but is there any other questions from members before I do that, and then we'll have a consideration ourselves? Anybody on the phone with any other points before I let Cathy and Craig go? No. Okay, Cathy and Craig, thank you very much. It is a hugely complex area, and I think that speaks to the need for us to consider it very, very carefully. But thank you for your time. Can you, if there is any further clarity in relation to those areas that we've touched upon but that you weren't able to give full details on, Cathy, can you ensure those are back with us for consideration?
Yes, that's fine, Chair.
Okay, thank you, and thank you both for coming along and for presenting that to us and giving us those answers. Thank you, Cathy and Craig. Okay, bye.
Thank you. Thank you.
Thank you.
I would. This seems like a massive area to be considered so quickly. I have to say, it's because it could have huge ramifications for a long period of time. Can we get the report drawn up and defer the decision until next week till we see the report and finalise the report then?
Yeah, I mean, what I can do is draft up a report that talks about that references the questions you raised, and to the extent that I can get any clarification, make sure that the detail, the explanations you were given and any further detail that I can dig up is listed, and then stop short of putting in the committee's view. Just leave you to make your view as to whether you, because your report will need to indicate whether you support the motion or you're going to oppose the motion ultimately. So I can leave those two options in for the committee to decide at the next meeting.
Can I ask as well, Eilish? I mean, I don't know if anybody else got it, but I'm still puzzled as to what is being decided. I mean, I understand the content of the bill in Westminster and the LCM here, but what's being decided by the Health Department and the Minister in terms of future changes? Is it everything, or is there only some aspects of regulation changes? So I'd appreciate if that could be relayed. I don't know if people
Chair, I
got
would
clarity
propose
on
maybe that if the committee's content, I could liaise with the member and draft up a letter to seek clarity on that matter.
Thanks.
And share that with all.
Share that with everyone and use the response to inform the report.
Thank you.
Yeah, so we'll defer our consideration then and come back to it next week to see if we can give that some further thought. Members content with that?
Yeah, Chair. Just to say, I was under the understanding that this is simply a piece of legislation intended to delegate powers to devolved regions under a common UK-wide framework after the UK leaves the transition period. I mean, it seems to be a sensible piece of legislation in order to keep the status quo almost, to keep things moving. I think it's a necessary piece of legislation to actually keep those powers in place.
And that may be the case, and I think after further consideration that may be, but I certainly would like to give it some further thought and just to explore it a bit further. I just find it a hugely significant area of work to make a decision on foot of a 30-minute discussion on it. I think it bears some more consideration, but I'm not prejudging in terms of what the outcome might be. I think there's important elements of it, absolutely. But we are here to scrutinise it, and I think we should give it the fair chance. So members content that we come back to it next week?
Fine, Chair.
Okay.
Fine.
Thank you, members. Okay, I'm then going to go forward again to item 10. We've dealt with item 9 there previously. Item 10 is correspondence. So turning to the correspondence, can I refer members to correspondence at tab 10 of your pack, and to table papers and to the correspondence memo at tab 10.1. Can I draw members' attention to a couple of items? Item 10.2 is a response from the Minister to the Committee's request for additional information on the budget following the Departmental evidence session on 23rd and 30th of April. And do members have any comments on that? I was concerned with some of the elements of. I think it indicated that there were things that weren't being done now, and I I haven't had a chance to fully consider it, but I think it's something that it's a useful piece of information. But I think for now I'd be content to note it. But I think pending further scrutiny of budget issues, I think it would be well worth revisiting before any further scrutiny that we do. Members content with that? Yeah. Item 10.10 is the 11th report of the Examiner of Statutory Rules. So, may I remind members that the committee considered the following SRs at previous meetings, subject to the Examiner of Statutory Rules report, which we've done on many occasions. So, SR 2020-46, SR 2020-82, SR 2020-84 and SR 2020-86. I can advise that the Examiner has now made her report into all of those SRs and has no comments to make on any of those. So are members content to note the Examiner of Statutory Rules report? Members content, thank you. Can I also now refer members to the correspondence in the tabled papers? Oh, sorry, I'm going back just to your main pack, members. Are members otherwise content with the actions as noted in the rest of the correspondence memo?
Yep, content.
Yep, okay. So moving on then to tabled papers. Item 10.14 is a response from the Minister regarding issues raised during his attendance at committee on the 20th of May. Any comments on that? Are members content to note? Content, thank you. Item 10.15 is a response from the Department to some of our questions on the SL1 discussed last week in relation to coronavirus travel restrictions. Not all policy issues have been finalised, though I note the Department indicates it intends to go ahead and make the rule later this week. Are members content? Any comments on that? And are members content, therefore, to note the SR will come back for consideration to this committee when it is made. So are members content to note? Yeah. Thank you. So in terms of the tabled papers then, are any remaining items, are members otherwise content to note the rest of that tabled?
Sorry, Chair.
Yep.
Chair.
Go ahead.
Just before you move on, I wanted to come in on the response from the PHA and the RQIA about hospital admissions from care homes.
Okay, Pat, go ahead.
And that information is useful.
Pat, what item are you talking? 10.13 members.
Sorry, it's the last piece of correspondence in the main papers.
Yeah, 10.13 members, response from PHA and RQAA regarding hospital admissions from care homes. Yes, Pat, go ahead.
I'm just wondering, would it be possible to follow up on that and find out how many of those admissions, those people who were admitted to hospital, actually died in hospital? Because we're getting a picture of almost 50% of deaths have happened in care homes. But it seems logical to me that many of the patients who were transferred from care homes to hospital may have died there. I personally know of a number of cases where people have been transferred from care homes and died in hospital. So just to get a clearer picture of who is being affected by this virus, it would help if we could get that information.
Okay, would members be content to read off for that breakdown? Yeah. Members content. There's actually one item too that I had spotted I meant to mention there as well. The response on the 10.4 there, the response regarding free sanitary products for NHS staff, I thought that was a bit not dismissive necessarily, but not overly considered. And I understand there is a huge pandemic going on, but I thought it would be at the very least if it was turned down based on cost. And I didn't get any sense from the response that there was any indication as to what the cost of that might be. Now, there are obviously other benefits along with cost, including staff retention, mental health, staff well-being, a lot of other issues. But I wondered, would it not be useful if we were to seek an estimate of what, on the basis of what cost were the department ruling it out at this point in time? Would members be content to write and ask for what the estimated cost was that they were basing on for that? Sure. Yeah, members content on the phone there? Yeah, okay.
Content.
Thank you. Okay, so then I'm going back to our table papers and asking, are there any items on table papers that members want to draw attention to, or are members content to note those? Members content? Thank you. Okay, forward work programme now, section 11, members. We are, there are a number of items there within forward work in your pack. I refer you to tab 11.1 of the pack. And I suppose at this point in time, I just want to once again thank the committee staff here for the huge work they have done over the past number of weeks in rearranging sessions, rearranging briefings, often at short notice, carrying on throughout the Easter holidays and facilitating several meetings throughout that recess. So I just want to note that, but I also want to draw attention to we need to consider how we're going to manage meetings and business over the summer period as well. So the Chairs Liaison Group have discussed this, and there are ongoing discussions within the Assembly business team in relation to how business is facilitated over the summer months. There are a number of considerations, one of which is that I think there is work scheduled to take place in the building here throughout the month of August, maintenance work or updates to telecommunications. But in terms of, obviously this will all be contingent on what the Assembly come back with, I suppose, but in terms of our considerations, I think it's important to note that staff who work on the committees here are actually not allowed to take breaks outside of recess. And in order to provide staff and their families, and indeed our own constituency staff, with some element of certainty, I think we need to try to decide roughly what it is we would propose to do, so we have clarity, staff have clarity, and that we can continue to the greatest extent possible with the work. That is so important, and that has been so onerous over the last considerable period of time. I think it's also a very relevant consideration that while we as members all in a way sign up to this type of work, and we don't mind that, but we all, and staff as well to a lesser degree, but we all have family members who are also entitled to some certainty and to know, I suppose, what's happening. So I suppose I just want members' views. There would be, I think, a broad outline of a proposal that the Assembly will continue to meet throughout July, but that August there will be an attempt to facilitate that work and to facilitate a break during the month of August. So I'll just go around members, whoever we have here still on the phone. I'll go to Deputy Chair Pam Cameron first.
Yep, thank you, Chair. I suppose just to say that, yes, we absolutely recognise that the good work has gone on, and I think there's been an awful lot of pressure on the committee staff and indeed Assembly staff in the building, and also our own constituency staff as well. Certainly I know that my staff haven't had really virtually any time off since the Assembly came back, quite frankly. So I think there is a duty of care looking after other people. Yes, I agree with you, Chair. It's not about us as MLAs. We've signed up to this job knowing well that you don't get an awful lot of time off, and that's absolutely fine. But I think we do need to be cognizant of other people involved and their families and indeed their mental health. I think to some degree there would be no change in the fact that we always are able to meet at any opportunity when the need arises, and that would be even outside of a pandemic. That would always have happened within this building. If a committee needed to meet for any urgent reason, they did meet, and I know we would all agree to doing that, but I think we need to very much prioritise and ensure that we're meeting when we need to meet. If we need to meet with the Minister or the CMO or the CSO, or indeed need to meet to scrutinise emergency legislation or whatever that may be, we're absolutely there ready to do it, but we need to give some kind of certainty to staff members in particular, and allow the building to function, and whatever maintenance needs to happen going forward, and I do think we need to be cognizant of the fact that this pandemic is going to stretch out probably for quite a considerable period of time, and so things may not improve in the near future in terms of having opportunity to actually take that time out for staff members. So I think that's really important.
Yeah, and I think that's actually, and in keeping with what we did at Easter, that we had said that we would meet if a situation arose that required this health committee to meet, that we would certainly do that at any time or during any break. And I think that's been agreed by the committee, and that was the case over Easter, and is what we did in fact over Easter when we continued to meet, given the urgency of the situation at that time. So I'm going to go to Jerry.
Yeah, thanks, Chair. I mean, obviously staff do need break. The clerks and constituency staff and all that, don't dispute that at all. I think there probably is merit in August for some meetings to respond to events. There's likely, I'm guessing, unfortunately, to be more events happening this virus, and I think generally speaking, of no formal proposal, but I would feel comfortable getting some briefings in August as well, Chair. I think using that time, if possible, to get more briefings to prepare us for September and the autumn. So that would be my general preference, but I don't know how practical that is with staff and time off as well.
Okay, Alan?
Yeah, in relation to the meetings in July, Chair, I think that we should be prepared to modify the content and the agenda, the type of agenda that we would normally have, that we would always have people in from outside bodies to gather evidence. I think that we should maybe exclude that particular element of our work as far as possible, but obviously still retaining the capacity to take briefings from the Minister of Health and Chief Medical Officer and Chief Scientific Officer. But I think that it would help to minimise the workload of the committee staff if we didn't indulge in evidence gathering during July. I think that in August, I don't think it is unreasonable to clear the decks, as it were, and have no formal dates set for August, but with the absolute proviso that we are all prepared and ready and willing to come back at the discretion of the Chair or the Vice Chair to meet an emergency session. So that would be, and I wouldn't want that to be interpreted as some sort of a cavalier attitude or taking, turning a blind eye to the pandemic. It's not, but we have to be practical as well and consider our own health and our own capacity and our family's capacity. And I don't think it is unreasonable to have that certainty of a break in August, and particularly for the committee staff. I think it's absolutely essential that they have some certainty in August. But as I say, I think I speak for us all that drop of a hat, we'll be back in here in August if required.
Thank you, Alan. I'm going across to the phones there now, and I think we have Orlia first. I'll check if you're there, Orlia.
Yes, I'm here, Chair. Yeah, just similar to what other people have said. I don't think anyone is against not meeting when it's required that we need to meet. So it's probably just important that we'll communicate frequently as a committee and through yourself as the Chair, and whatever way we can do that with the committee staff as well, just to determine when we do need to come together to hold our health committee meetings. But I'm happy to meet whenever is required.
Okay, thank you. Do we have Pat on the phone?
Yes, I'm here, Chair. I agree with most of what's being said. I think we should schedule in meetings for July, but there is a need for a break, I think, in August. Unless there's some emergency or crisis arises that requires us to come back in, and I'm happy to do that. Can I?
Okay, Margaret, Marcin, Pat. I don't think we have any other members on the phone at this point. So, broadly speaking then, contingent upon the final decision of the Assembly structures here more broadly, I think there's a consensus that we agree that we continue to meet throughout July. We meet in August when, if necessary, and we make arrangements to keep in contact that we can do that, but that we will attempt to ensure that that there's no scheduled meetings in August, and to allow family members, staff members here, and the building work which is scheduled as well. Are members satisfied with that? Okay.
Content.
Thank you. So otherwise then, are members content to note the forward work programme as set out in your packs? Content, yeah, thank you. Any other business, members?
Sure, we have the trade union briefing next week, is that?
Which briefing?
The trade union briefing.
Yes.
Do we have a list of people confirmed yet, or we're still waiting on that?
Check with the clerk.
I just, I'll email that out to people.
Yeah, okay, thanks.
Okay, no other business members on the phone?
No, thank you.
Thank you. So all that remains with me today is to set the date, time and place of the next meeting. The next meeting will take place at 10:30 a.m. on Thursday, the 11th of June 2020 in the Senate chamber. Thank you, members, and that is our meeting concluded today.
Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly Committee Room 30. This is the Northern Ireland Assembly.